good, thank you, Declan. How are you?
I'm all good.
What are we talking about today?
Sex. Well, serious
I just
topic.
set that up for you.
You did, thank you very much. Yeah, look, a really, really important one tonight. We've done this a number of times over the years on GUcast, where we dive into the really important impact of treatment on patients, and particularly prostate cancer patients, the impact on sexual function, quality of life, and so on. So that's what we're going to talk about tonight here on GUcast. But we're going to do it with a proper world-leading expert in the topic. It's a really big thrill for me to welcome back my old friend Chris Nelson, psychologist from Memorial Sloan-Kettering, who's back in town, back in Australia, touring around the place.
For sure. Yeah, no, great to be here. Thanks for having me.
Doing a whirlwind tour of the Asia Pacific region.
I came to Melbourne just for this.
Oh, yeah, that's it.
Sure,
exactly.
Yeah,
well, he also came because, of course, Melbourne is the home of Movember, and what I'm holding up to the screen is this really important document, which is what we're going to talk about tonight, the Movember-supported guidelines for sexual health care for prostate cancer patients. Right. So, as we were talking about before, Chris, we have a real mixed audience right now, don't we? We have predominantly healthcare professionals, I think, working in GU oncology, but we certainly have quite a lot of patients listening to us from around the world.
That's great.
And the industry, people working in the industry of GU oncology, especially prostate cancer. So therefore, I think this is a topic that hopefully will be of interest to everyone.
And a really important document, isn't it? So a lot of work's gone into it. Obviously, with so much of your input, Chris, and I think it's important not just to go through what's in it, but also, what are the plans to get this information out there?
Yeah, perfect.
So that's going to be the core of it. But before we do, Chris, for those of you who don't know you, I must have met you 15 or 20 years ago on previous trips here. But and we've been very aware of all your work in the area supporting patients, and you've been very involved in the psychology service, of course, at Memorial Sloan-Kettering, our friends at Memorial for very many years. So tell us a bit about that, about your role at Memorial and your role in supporting patients like this.
Yeah, and so I'm a psychologist, and I'm in the kind of a niche field called psycho-oncology. And so at Sloan-Kettering, we have a number of psychologists, psychiatrists who see all types of cancer patients. I specialize in men with prostate cancer, and so kind of I see that group and try to help them adjust and cope and deal not only with the diagnosis of cancer, but in terms of, we'll talk about today, the side effects of treatment, how it impacts them.
Yeah, I think we focus so much on the impact of treatment, which does really have an impact on sexual health and therefore the emotional aspects of that, but also the diagnosis. That's a huge point at which I think it's important to have the service.
Yeah, for sure. Diagnosis hits men hard.
Yeah.
They'll talk about it as just crushing, right? This notion of out of the blue, prostate cancer, right? You really don't feel anything. There's really,
that's right,
most of the cases, there's not any signs, any symptoms, and men will say, like, I was healthy, and then I was diagnosed with prostate cancer, and I felt like I've aged, 10 or 20 years. Yeah, absolutely.
And the thing is, Renu, Chris works in a glittering cancer center in Manhattan, and, I know you have a lot of patients, but you have a lot of resource as well. But for a lot of people out there, we don't have a lot of resource in the cancer center or in the local hospital or in the primary care to provide good psychological support. So I suppose the guidelines do go a bit away towards that. It's not to say, you all need to be in one of these, top world ranked cancer centers where you do have a lot more support. We should be trying very hard to support patients regardless of which setup we're in.
Yeah, and so that was really part of the goal, right, of the guidelines, was to try to get all the information, evidence-based, kind of what's the best information available for clinicians and for patients. And so clinicians bring up the question, ask the question, right? How's your sexual functioning? How has the treatment impacted you in terms of your sexual functioning? And then, we have the resources or a place where you can go to look up kind of what those, what the best treatments are, and where patients can go to look up those resources.
Yeah, awesome. And so this document, and as I said, we'll put a link in the show notes, outlines. It's not a long document. It's really concisely put down, but Movember have supported this. So tell us, first of all, a bit about how did this all get put together? What sort of stakeholders were involved? And then there are 6 kind of key guidelines, Renu. So we're going to pick Chris's brains while he's here to answer these questions about the 6 key areas that we should be addressing for sexual health for patients. But before, tell us a bit how you put it together. And there's a really nice flow chart that talks a bit about psychological impact, body changes, interpersonal, sociocultural, etc.
Encompasses much more than what you would think about when you talk about sexual health effects from treatment. So it's kind of all encompassing, isn't it?
Yeah. Yeah. And so what we wanted to do is take what's called a biopsychosocial approach, right? So, oftentimes when we think about medicine, we think about the biological, right? And of course, that's the first place we want to think, right? And that's where we want to focus. But for sexual functioning, so much more than the biological goes into it, right? So you have the psychology of the person, what's happening with that man impacted. Is he nervous? Is he anxious, right? Is he really distressed, upset about the impact on sexual functioning? Of course, then he's potentially in a relationship, right? And so you're with your partner and kind of those relationship aspects come out. And that's all couched or, and placed in the culture, right? Or kind of what's their religious background? What culture are they in? I was just in China talking about sexual functioning and talking about these guidelines a little bit. And, and their sense about talking about sexual functioning is just much different than, let's say, the United States or probably in Australia. And so all those things impact, kind of how we think about sexual functioning and then how we best work with these men and these couples to address it.
Great. Well, let's dive into it. So there are six topics. So Renu, let's fire off. What's the first one?
That's right. So section, I mean, it's so nice. It's just beautifully divided into the different sections of the guidelines. So section 1 is counselling patients and their partners about the impact of prostate cancer treatments on the biopsychosocial aspects of sexuality. So give us a little rundown on that. And I mean, it's all about counselling patients about the impact.
Yeah, and really, when we think about it, so one of the biopsychosocial approach, let's counsel them on that. There's multiple factors that might impact sexual functioning and your ability to react to it and kind of move forward from it. But a piece of this first one certainly is talking about how we counsel patients, how we talk to patients and their partners, even before treatment, about the impact and how can we adjust their expectations so that they know that, listen, any kind of radical pelvic treatment is going to impact sexual functioning. It just is. It doesn't matter how good we are. It doesn't matter about how advanced the treatments are. It's going to impact sexual functioning to some extent. Like every man takes a hit. And getting that information pre-surgery or pre-radiation or pre-treatment, whatever their treatment is, this part of the idea is how can we get it phrased and how can we get that information out to patients, even pre-treatment.
How receptive are patients at that point? Because pre-treatment, a lot of men are worried about the diagnosis, the cancer, the oncological outcomes. Those
like
really
all those things,
pressing functional outcomes. So how receptive do you think they are, and how important is it?
Great question, right? Because so if they're sitting with whether it's a surgeon or radiation oncologist, and they're talking about their treatment, they're focused on their treatment. There's just no doubt. And so the surgeon could give the best overview of what's going to happen in terms of the impact of sexual functioning, and how much is the patient really going to take in. However, even doing that helps the patient for sure. And then other strategies are potentially even more helpful. So that is, can there be a separate meeting with a nurse practitioner, really talking about not only the sexual side effects, but what other side effects of treatment, are you going to experience? There's other institutions, the University of Michigan does actually like a pre-treatment group once a month. So all those patients who are going to be treated, whether it's surgery or radiation, they do a group, and the groups run with a nurse practitioner, a psychologist, and they talk about kind of these impacts, again, from urinary incontinence to sexual functioning. They're on ADT, kind of what are the side effects of ADT? And so there's ways and strategies that you can even increase kind of the way that patients can uptake that information, because you're exactly right. When you're talking about treatment, they're focused on treatment. It's about cancer. Even then, it's really good to talk about those things because it'll help patients. But if there's other avenues where you can get that information to patients, that's even more helpful.
Chris, what Renu said strikes me that beforehand, they've just been diagnosed with prostate cancer and there's a lot to take in. And often I will hear from patients, well, look, when you're trying to go through these main domains, it's, well, the cancer is the most important thing. I'm 60, I'm planning to retire. That's the number one thing. Number two, leakage. I play a lot of golf, and I have a friend who has to wear. I don't want to. And sexual function, I accept there'll be some changes and so on, and that's the priority for me. But the thing is, for very many patients, the cancer will be fixed. the continence will be fine, after some leakage, the vast majority of patients will. So by 6 months later, the thing that they said, that's the least important, I can live with that, is the only thing potentially.
That's right. Yeah.
So
it becomes the most important then, for sure.
Absolutely,
Yeah.
yeah.
So I'm looking for your advice on that, I suppose, is when confronted with that, I will very often say to patients, well, look, I think with your type of cancer, you're highly likely to be cured by surgery or radiation. You're highly likely to recover very good quality urinary function, in my expectation in your patient. So those two things, but so therefore the only thing left. So, or have you tips for how do we address this when people are trying to deal with the confrontation of a few things to think about? Oh, I've got cancer now, and impact on this and impact on that.
Yeah. So, and I think being as direct and honest as possible then, and, kind of indicating that, listen, just like you said, hopefully with your cancer, hopefully we're going to get this, right? Urinary incontinence, we'll be able to hopefully address the urinary incontinence, and there'll be a period, but hopefully kind of you'll recover continence. But let's take a minute just to focus on sexual functioning and talk about the impacts, because this is going to be an impact. And, unlike urinary incontinence, it could take up to 2 years to recover something like erectile function. And so it's going to be a long haul for these patients. And the more you can get those expectations up front, really the better.
Yeah, absolutely. And it makes it easier to approach that topic afterwards as well.
Absolutely.
So if we move on to the second section, so this is a bit more specific. It's about what patients and their partners should know about the impact of those individual treatments. So whether it's surgery, ADT, and those individual therapies on sexual function. So what are the recommendations for that?
Yeah, and so the recommendations are really kind of, again, talking whether it's pre or post-treatment about what those implications are. And so, and let's just take a step back and think about what those are. And let's think about just in general, right? So the thing that we think about most is difficulty with erections. We know the treatments are going to probably impact those to some extent, and there'll be a recovery phase after surgery, after radiation. You'll see a decline over time. There's some differences in terms of responses to the PD-5 inhibitors, but they're there. Penile injections are there. That's the big bucket. What's often not talked about are some of the other implications for men. And so those are related to orgasm changes. Like 90% of men will say their orgasm has changed to some extent. There's a small percentage who will say it really has gotten worse. There's a small percentage who will say it's improved, actually.
It's intense,
yeah, it's more intense. And so things like ejaculation, right? Every man after surgery is not going to ejaculate. After radiation, you see a reduction in ejaculate, up to 3 to 5 years. Things like sexual incontinence. So foreplay incontinence. Men might leak during foreplay. Sometimes men will even report, like, I just think about sex and I leak a little bit.
Yeah.
Orgasm-associated urine leak, climacturia. Yeah. So things like penile morphology changes, like have they lost length or girth?
That's a really important one, yeah.
Penile curvature, and then loss of libido, right? Yeah. So men for sure on ADT are going to lose libido. I mean, we all know that, right? And that's one of the main side effects. But even for men who, like, if you think about all these things, so if they have difficulty with erections, their orgasms had changed, they're leaking it, kind of in foreplay. They think their penile length has changed, the girth has changed. All those things are going to impact just your libido and your interest.
Yeah.
Men will say, like, sex used to be fun, and now after these treatments, like, it's just so different.
Yeah.
One of the things, that our intimacy specialist, Victoria Cullen, I know you know Victoria from A Touchy Subject, she's been in here. Yeah. And I remember her speaking very eloquently like you do before about this, and she says that it's a journey after these treatments where things are evolving. And she often spoke about the fact you have to move away from a focus on rigidity and penetration more towards intimacy and orgasm. Okay. And maybe on a pathway back again to having some rigidity and penetration. But if you adjust your thinking and your mindset, it is a journey. But maybe don't immediately think, how am I going to get the rigidity? And that there are other ways to explore the relationship and the enjoyment through intimacy and orgasm rather than rigidity and penetration. So any thoughts on speaking about the journey or the evolution or changing the concept of it? It's all about the erections. That's right. Which is the most difficult thing to get back, at least quickly. That's right. But there's other ways of evolving, enjoying intimacy and orgasm. It's a really good point, right? And so men are hyper
they're hyper focused on erections. You know, forget prostate cancer treatment, right? When you think about men and sexuality. So if you look at the research and you kind of, you know, the research, what's men's favorite thing in a sexual situation versus women's favorite thing in a sexual situation? And, you know, I have this discussion with men all the time. And the research really shows, so for men, what is it? It's like an erection is number one. Number two is an erection. Is number two, right? Number three is an erection. Right. Number four is penetration. Like you get your, like maybe down the list is something like intimacy or closeness or togetherness. Yeah. But if you look at the research for women, what is their favorite things in a sexual situation? Intimacy, closeness, foreplay, togetherness. Penetration's on the list, but it's lower on the list. So when I have this discussion with men, of course, they look at me like, what are you talking about? But there's a difference, right, between men and women, and they're in kind of, you know, how they think about sexuality. And it's trying to bridge that when men are having difficulty with erections. And so part of that journey for men is a sense of, like, they just, you know, just changing like that is difficult. So it really is a journey. It's a sense of grieving, kind of what's happening with their erections, and really helping men try to change their perspective that you can still have a quality sexual relationship. It's going to be different. You can still have a quality sexual relationship that's not so hyper-focused on erections and penetration. We're going to help with that. We're going to get that back. There's actually ways to get that back. We're actually pretty good at getting erections back.
Yeah.
But, you know, let's think about it differently, and how can you two communicate in a way that can push it more towards the notion of intimacy, closeness, orgasm, as opposed to erection and penetration. Yeah, so it's a really good point.
It's really quite eye-opening, and Victoria talks about this too, because often a lot of the issues that come up in a couple's relationship is because of that miscommunication. Absolutely. What one partner perceives to be important is not what the other partner perceives to be important. So it's an important opportunity to improve that communication. Absolutely. And still have a very healthy sexual life.
Yeah, you know, I often talk like oftentimes men and women are really kind of on different planes, and part of it starts with if it's a heterosexual relationship, right? And so part of it starts with kind of, in a heterosexual relationship, the wife or the woman, female partner, is really trying to be supportive. And they say to the man something like, listen, I'm more interested in you being alive and the cancer gone. And, you know, really your erections aren't that important to me anyway. That's okay that you don't have erections.
Yeah.
Right? They're trying to be supportive. What the man hears, like, what do you mean my erections aren't important to you? Because for me as a man, my erections kind of go core to what it is to be a man.
Yeah.
And so then what happens is you have the couples really talking like this. And so it's the importance of getting the couples together, as you said, opening up that communication and talking kind of on all these levels. Yeah. But again, just how can you move forward with a quality sexual relationship? Probably going to be a little different than before treatment. That's okay. It can still be a quality sexual relationship.
Absolutely.
All right, Renu, number 3.
Moving on to 3, and this is about the importance of assessing both sexual function and distress, not just in the patient, but also in the partner. And what are the guidelines saying about that?
So we know kind of what we think about most is assessing sexual function, right? So most of us know, like we have ways to assess erections, what's happening with erections, what's happening with sexual functioning. But this really talks about the importance of assessing and understanding men's distress, because this is actually really distressing to men. We know there's been really a number of quality population-based studies which have really outlined the relationship between erectile dysfunction and depression. And we know that it hits men hard. And then thinking about the distress and how does it hit the couple. And so number one, yes, sexual functioning, we're all probably pretty good at that, right? I mean, I think we all know how to assess that.
Yeah.
It's the distress, how is the man taking it, and then what's happening with the couple, adding that to the assessments to make sure you're, again, the biopsychosocial perspective, not only assessing the biological, but what's happening psychologically with the patient, what's happening relationship-wise with the couple, and how is that couched in either the religion or the culture?
So, I mean, it's going to be really hard for you as a sole practitioner to see every patient. So are there screening questions that their surgeons
Absolutely.
Or physicians can do to assess distress?
Yeah, absolutely. So, and we're not suggesting that. So number one, we're not suggesting like a huge assessment, right? And we're not suggesting that a urologist or radiation oncologist is actually going to treat them for this.
Yeah.
Being caring and supporting is a really great first step. Normalizing the experience is really important. But these are not complicated questions. It's how are you coping? How are you coping with the changes in your sexual functioning? Is it really distressing to you? Okay, well, let's get you some help with that. How are you two as a couple dealing with the changes in sexual functioning? And if you see kind of the distress, or they indicate, well, it's been hard for us, then hopefully you can indicate or then refer to other resources. The guidelines are really a good place to go for that. Yeah. The other piece in working with the guidelines, a group of us from the International Society of Sexual Medicine, ISSM, have actually teamed up with Movember to disseminate these guidelines. And one of the things that we've developed is a website, issmmovember.com. It's issmmovember.com.
We'll flash it up.
Yeah, we'll flash it up. Good.
That's 2 M's.
Oh, good point. Yeah, we'll flash it up there. So, but ultimately, that's a website where what we're doing is we're putting really the latest evidence-based treatment for providers and for patients. We have videos, we have toolkits, we have kind of, information so that you don't have to feel de-skilled if you ask these questions and not sure where to refer patients. Yeah. You can refer them to that website. It's vetted by kind of those of us who really work in the field, international group. And so you can trust it, and you can, be confident that you can go to that website and there's good information there. It's a place to refer patients.
That's fantastic. And we'll put the links obviously in our show notes.
Now, the first 3 elements of the guideline were about counselling beforehand and assessing the patient and so on. But the second 3 are about treatment then, it strikes me. So number 4 here, Renew, what have we got?
Yeah, so that's and these are the kind of things that you mentioned before. It's the biopsychosocial. So the section 4 is really about the importance of the psychosocial treatment and counselling patients about that. And section 5 is counselling patients about the importance of the biomedical treatment. So tell us about those. I mean, you're hitting on all the aspects.
Yeah, and so we've talked a bit about the psychosocial pieces, right? And it's really we're not asking you to ask complicated questions, right? We're asking just to assess kind of how the distress is, again, for the patient and the couple. And then really kind of the medical treatments are those medical treatments, especially for erectile dysfunction, that most people are already familiar with, right? So they're the PD-5 inhibitors. That's going to be your first line of treatment. And then for men after surgery, we know biologically, in terms of kind of what's happened with the nerves and nerves healing, that PD-5s might not be effective kind of as those nerves are healing right after surgery. It might take, could take 9, 12, 18, 2 years before those PD-5s are effective. And in that period, treatments like vacuum pumps are really the penile injections are really effective, right? And so we know that penile injections are actually probably the most effective treatment we have for something like erectile dysfunction. 90% of men will respond to those. And so it's those types of treatments that, we list and that are there. Yeah, for your reference.
Yeah, absolutely. And a lot of it is about taking the fear away about those treatment options as well, because when you see their face when you first mention injections and you're like, what? But it's kind of, there are myths out there that you just have to bunk down and.
So thank you for bringing that up, because actually my work has really kind of dealt with that piece of it. What's interesting is, I'm at Sloan-Kettering, and there's sexual medicine professionals, John Mulhall at Sloan-Kettering. And so I started working with John over 20 years ago. And so when I started working with him, he said, Chris, like I can get their erections back, right? That's not the problem. The problem is that they don't necessarily use the treatments. Yeah. And I really want to work with a psychologist about how we help them, use the treatments. And essentially what happens is anxiety and fear starts to basically accumulate when you think even about using an injection. And it's not necessarily about the pain of injection. Once they use it they realize it's not very painful. But it's the fear of entering in a sexual situation when they're not confident that they'll get a firm erection. And men become very anxious and nervous about that. And so what happens is they think, oh, maybe I'll use the injection tonight. They become nervous and anxious. And then they think of a way to avoid it because they're nervous about it, right? And as soon as you avoid, instant mechanism, you're not feeling nervous anymore. However, and then you avoid, and there's something that you really wanted to do, a valued life experience, you're not doing anymore. And so you become more distressed. And so, so I've really that's been an area where I've focused on and developed some specific interventions, but working with a mental health professional, working with, kind of whether it's a sexologist, working with someone in your practice that can help patients really think about kind of a way to use these treatments can really be helpful.
And Chris, regarding the timing of injections, so very often patients will be recovering from surgery and they'll say, tablets, I don't mind, they're easy, even if they don't appear to be immediately effective. Vacuum erection devices, we certainly encourage them early on, just to, suddenly the erections are gone and you do get girth back. It's like exercising the penis. But a lot of patients will say, look, injections, I'll give it a bit longer, etc. And I find, it can be many months later. Or someone will say, I won't be doing that. But have you thoughts on timing of this and respecting individual patients, what they're prepared to do or not? Or how do you speak to patients about that? Or
Well, so I think if you look at the data, right? If you look at kind of the basic science data and then some of the other data looking at kind of the notion of when you start these treatments, when is this most effective and most helpful, earlier the better. And so, of course, men are going to say, I'm going to put an injection where? We've all been through that, right? Yeah. So there's going to be some resistance, but the more you can try to break through that resistance sooner rather than later, the better. The better not only potentially biologically for the notion of rehabilitation, but the better in terms of things like increasing sexual satisfaction, getting to the point where they're more confident in a treatment that can help them get an erection, then they're more confident in thinking about entering into a sexual situation, which will make them less anxious, hopefully will help the relationship. And so, yes, pills are the tablets are the easiest. The vacuum devices may or may not be kind of, more inviting to patients than the injections, right? But the more you can fight through that resistance and actually help the patients use the injections sooner, the better, both from biological perspective, but also from the psychological kind of relationship perspective, no doubt. Yeah.
And undoubtedly, Renew, the role of clearly not the urologist, but other professionals in that area. If you have psychologists with a particular interest like Chris, or we have some fantastic nurse practitioners work with us, or intimacy specialists like Victoria. So they're the ones there to support, but we probably do have a role to sort of, reassure patients about that. So I'm listening to you very carefully because I probably should, push that forward a little bit more to say, come and talk to Emma and Luke and Tiff and Mark and co about this option, not 6 months later, but come a little bit sooner,
Yeah. And listen, I usually talk about it. I say, look, the first thing you think about is pain, right? And so we've actually done the research on this. We've actually asked men, how painful is that injection, the penile injection? And so I usually talk about, I'm talking to a man, I said, so now you're thinking like on a 0 to 10 scale, 0, no pain, 10 pain as bad as you can imagine. You're thinking it's off that scale, right? That's how painful you think it's going to be. But the research really shows that actually men rated a 0, 1, or 2 on the pain scale. It's a thin needle. And so this is not painful. You try it once, and let's give you a chance to actually get your erections back and see how it works. If you try it and you don't like it, and you try it for a month and it's really not something you want to do, okay, but let's try it now, sooner rather than later, because there's some benefits to you doing it sooner.
Absolutely.
And often if it is a few months later as well, patients are, much more accepting of it because it may be 3 months or 6 months now since they've had a reasonable erection, if they had good erections before. And you're saying, okay, well, look, if you do this injection, 10 minutes later, you have like 80-90% chance of having an erection back, the thing you haven't seen for that long a period.
That's right. Yeah, that's absolutely right. Time helps. There's no doubt about it.
And the final one, Renew, this is a really important question we get asked all the time anyway.
And such an important one. And these are lifestyle changes, stop smoking, alcohol intake, diet, exercise, because not only can they affect the physiology of erectile function, but they also affect a man's psychology in such an important way. And it's all about breaking that vicious cycle. Mm-hmm. So super important.
Super important. So those types of things, right? The things we know about, right? Mm-hmm. Stop smoking, right? like those types of things. Really, for men with prostate cancer, one of the things that I push the most is exercise. Mm. And if you think about exercise as a way to help men with prostate cancer, so ADT kind of in terms of an intervention, something to help men cope with the impact of ADT, exercise for me is clearly kind of the best, and it works kind of, men report that as kind of what works the best for patients. But also just in terms of things like erections. So Daniel Galvao, who you're here in Australia, right? Edith Cowan University in Perth, right? So part of what, so they've done some really excellent research, right, with men with prostate cancer on exercise. And so they actually looked at sexual functioning in one of their studies. And those men who were in their exercise program reported better erections. They reported kind of higher sexual satisfaction. They reported things like, better orgasm satisfaction. You could see just across the board the improvement in their sexual functioning, even with an exercise intervention. And so those types of lifestyle changes and interventions are really important for all aspects of these men.
Way better than X number of drugs and supplements and so on. Yeah. And good for the heart.
Yeah.
Well, look, that's awesome, Renu.
As our friend Tim Baker says, don't forget to take your meds.
Yeah.
And it stands for meditation, exercise, diet and sleep.
Yes.
Yeah.
Oh,
So,
perfect.
all those,
perfect.
Those things that are really important. Wow, what a great document. And I
really
think
good,
it's so important
Yeah.
for people to know that it's out there. It's a great resource. It's and look, I mean, if physicians and their patients are directed to this, it might even save a lot of referrals to more tertiary practitioners.
Absolutely. Well, and that's the idea, right? This is, the information's there. It's there to use. Hopefully and again, if we think about that website, ISSM Movember, that website's meant for practitioners and for clinicians, right? To have this information there in a really useful way.
And patients can browse it, or patients can direct their clinicians towards it.
Yeah. Yes, please. Yeah.
And I know you're on a dissemination strategy in association with the ISSM, the International Society of Sexual Medicine, and Movember, of course. So, well done to everyone involved in that. And we're doing our little bit, I suppose, Renu, in helping the dissemination strategy.
Yeah, we appreciate it. Absolutely. Yeah. So
huge congratulations, Chris. I mean, you've dedicated so much of your life and career to helping these men and now physicians who deal with prostate cancer patients.
Yeah, thank you.
And your great colleague, John Mulhall, good to hear his name.
Sure.
He's a good friend of ours from the olden days as well.
Of course, yeah.
So well done to Donna and everybody at Movember. Thanks for steering Chris our way on his visit back to Melbourne here. But you're heading out for dinner now. And so we got to let him go, I suppose.
I suppose so. Could talk forever, but...
Great. Well, look, thanks very much. Thank you, Chris, again.
Thanks for having me.
Great to see you. Keep up the great work. And thanks to everybody for listening. And we know this will be a popular topic, so please do share it out among your networks and go and look at those resources. The links are in the show notes. That's all we have time for. We'll be back soon again.
See you next time.
Thank you.